Welcome to Eyes on Dry Eyes special session here on how to implement a dry eye protocol in a surgical practice. I'm Dr. Davidson. I'm an optometrist with Williamson Eye Center in Baton Rouge, Louisiana. Excuse my gruff voice. We just watched the Super Bowl here a couple days ago, and we were rooting hard for a lot of our patients and a lot of our friends. A lot of Tigers and a lot of Wolverines were playing, and I'm still a little bit hoarse.
Go Bengals. Go
Bengals, yeah. During the end, Joe couldn't quite pull it out. Man, I tell you what, but we had a lot of LSU Tigers that on both teams, so that was fantastic. And Dr. Blake's actually done surgery on quite a few of those NFL players.
Oh, yeah.
So we're tightly intertwined with those folks. So again, forgive my gruff voice. During the Q&A section, we should be live, and you should definitely get a little bit more cleaner sounding name. My background, I actually went to the Michigan College of Optometry, way up in the north. So I grew up in a hand, state shaped like a hand. Now I'm in a state shaped like a foot. So great to be here. Undergrad at University of Michigan, graduate school, Michigan College of Optometry. I've always had an interest in dry eyes and specialty lenses. And I've kind of dabbled in various optometry environments, and I finally found my home here at Williamson. I've been here for 3 years, and it's been the best 3 professional years of my life, and it's not even debatable. So this is Dr. Blake Williamson.
Hey, everybody. Blake Williamson, and I really appreciate, Josh, you having me, and Damon, and everybody at Eyes on Dry Eye. I just think it's so cool that we're able to bring together ophthalmology and optometry to talk about such an important topic that really affects everything we do. You know, I sometimes refer to dry eye as like the diabetes of eye care, in the sense that diabetes can affect everything systemically. Dry eye can affect everything inside the eye. So I think it's critical that we're having these meetings and having these symposia. So thank you very much. I'm honored to be here. So my background, you know, I'm born and raised right here in Baton Rouge, Louisiana. And I went away to Ole Miss for undergrad, and ended up kind of taking a circuitous route through medical school. I did my MPH at Johns Hopkins, did my ophthalmology capstone there, and participated in a lot of research in Prim Submarinian's lab, as well as the lab of David Friedman. After that, ended up doing a Master's of Science focusing on biochem at Columbia University in New York City, and then ultimately came down and did my medical school and residency in New Orleans. I did my training for ophthalmology at Tulane University, and then after that did a 1-year private fellowship here at Williamson Eye Center with Dr. Charles Williamson. My interest and hobbies really are my kiddos. They're 7, 3, and 2, and refractive surgery. That's kind of my gig. It's kind of, we live in a space where your job can kind of be your hobby too.
Yeah.
And I know that Josh is like that too. So I'm so honored to be here, and look forward to speaking and learning from you guys.
So what we're here to discuss is how we have built, I personally think, a world-class dry eye center within the Williamson Eye Center. The Williamson's been around for a very, very long time, and it's very well known. And I'm going to kind of let you take that lead and kind of discuss where we came from and kind of where we are now, and how our clinics are structured.
Yeah. So in this next slide here, you see how, you know, it's important that you understand kind of where we were, and to appreciate kind of how far we've come and where we're going. So just so you have a background of what we are, we've been in our practice, our practice has been in our market for 75 years. It's actually started by my grandfather, who's an optometrist, Dr. William Williamson. So we really came out of optometry, and he saw early on the opportunity to sort of partner and have collaborative care with surgeons and optometrists at the same time. So he had 4 sons. All 4 of them went into ophthalmology. 3 as ophthalmologists, 1 as a PA working exclusively in ophthalmology. So I like to joke we're a very non-creative family. Everybody keeps doing the same thing over and over. But that's kind of what my grandfather created here. The structure of our clinics at this point, we're kind of like a hub and spoke model. So we have our main campus here in Baton Rouge, where we have our surgical center. We also have another sort of a refractive suite inside of a big hospital medical office building. But then we have 6 other satellites that sort of surround us and are adding more every day. It's our philosophy that if you're not growing, you're dying. And so we really like to function almost like our own private equity company, where we're finding practices in different communities that could use our services and acquiring them and just building a bigger and bigger network. And I have to say that all of this bodes well for our dry eye center, because I had this idea several years ago when I started. I'm only about 5 or 6 years out. We weren't doing anything for dry eye therapy really. So I was the one that kind of started with some of the point of care diagnostics and some of the treatments like microblepharoid exfoliation and thermal pulsation, all that type of stuff. But really, we needed a practice champion, and that's where Dr. Davidson came in and has taken it far beyond I could have ever intended.
And yeah, that's a great point. Williamson is so well known in our area, and the fact that you are so OD friendly is one of the things that really enlightened me, and it really got me excited to work with y'all. So it's something that you're really, really well known for, and I'm just thankful to be a part of it. And the great thing about it is when I got hired in, I said, listen, dry eyes affects everyone. It affects everything you do. And it's getting more and more common. We know as we spend more time in front of cell phones and tablets and computers, as our world is getting more near to us, we're actually getting a little bit more nearsighted, and our eyes are drying out because we're blinking less. So dry eyes aren't going anywhere. In fact, I would expect it to get progressively worse. And especially in eye care, we live by that mantra, if you're not growing, you're dying. Well, what better place to grow than a disease process, which it is. It is a disease process that more and more people are getting every single year. And so that is really, when I got hired in, I said, I really think we need to really ramp up our dry eye care. There is a huge space in the market for this, and we can help a lot of people. So my passions were dry eyes and sclerals, and Dr. Blake and Dr. Charles, and really the whole management team have given me the tools to really follow that passion and build and help build this with their guidance. And I think that's the really big thing is, if you've got a surgery center, is it really worth your time as a surgeon to be seeing these patients every couple of weeks, every couple of months, nitpicking their dry eye, especially if your passion is in the surgery suite, because that's where your passion is. My passion is not there. My passion is helping these dry eye patients. So they were able to, find me, team up, and we both are following our passions and really doing what we're interested in. So that would be one of my biggest take homes. If you are a surgery center, if you're an MD, and you're looking to really get more into the dry eye space, if you can find an optometrist that really loves this stuff, that loves those patients, that's a great, great spot to start.
Yeah, and I'd add to that if you're a surgeon watching this and you prefer to be in the OR and you don't have time, quote unquote, for dry eye, follow up and therapy pre-op, just understand that you're going to lose so much time on the back end of that unhappy post-op. And that's such a huge part, as we know, of these different presbyopia correcting lenses. They're kind of like Ferraris, right? Foreign cars that are, require a lot of maintenance. Everything has to be pristine. So you end up losing a lot of time on the back end, I'd say.
I think that really brings up a good point. On that slide right there, I made sure to put kind of the mantra that I live by if I see a patient with even mild dry eyes before I send them over to you. If I tell the patient before I send them to you, hey, you've got some dry eyes, we're going to work on this, and it's something that there's no cure for, but we can make better. Dry eyes are their problem. Yeah. They understand that. They have this issue.
Yeah.
If we tell them after they have that surgery,
we caused it.
Suddenly it's our fault. It is purely our problem. We did this to them.
Yeah.
And I think that's a really, really important point to know from a surgical standpoint, even ODs that are just sending to you.
Yeah.
You don't want a patient that one of your many referring doctors sent to you. You look at their eyes and there's SPK and there's chemosis, and it's just a nightmare. You shouldn't have to be the first patient or the first doctor to tell this patient, hey, they have dry eyes.
Yeah, and I don't want to send that patient back. They're like, gosh, why was I sent in the first place?
Yes.
That's critical. And I'll add with, if you don't diagnose it, you caused it post-op. I'll add to that by saying one of the best tips I can give folks watching this is that if if you can just remind your patients before you send them for cataract surgery, if they have dry eye, if you could just remind them that oftentimes the number one, symptom of dry eye is blurry fluctuating vision. That is huge. A lot of times people think it's dryness, right? But by telling them on the front end, when they end up with a little bit of blurry fluctuating vision, you have that 20/20 minus patient who's complaining they can't see anything. Boy, does that help that you reminded them that on the front end. So I think that's a key thing as well.
Absolutely. And, before we exit this slide, I really want to bring us back to the fact that the dry eye market, we are in business. We have got to keep the lights on. The dry eye market, there's some studies that say 5% of the population in the US have it. No way, way more than that. There's some that say 50%. That might be a little aggressive. So even if you kind of split that difference, 25, 30% of the market, or the population, that is a huge, huge market. And as we all know, who is your typical dry eye patient? It is that typical middle-aged female, the mom of the house. And, if she's anything like your mom, your wife, they're the medical decision makers. So these are the people that you can get to. You can treat their dry eyes that no one else has ever been able to treat. And you know what? They have a great experience. Suddenly you're seeing their kids. Suddenly you're seeing their parents for cataract surgery. Suddenly you're seeing their neighbors, their church friends. It is a great way to build your clinic downstream. So even if, you look at that dry eye clinic and, your numbers are just, growing slower than you'd expect, which, I think we've been blessed in the fact that we've been growing quick, but it's also the fact that you're growing every aspect of your clinic if you want.
Yeah.
So I think that is a huge, huge, huge point there. Next slide. Couple things. And really why a dry eye center in a surgery center makes sense, in my opinion. I don't like to read off slides, but this is a really important point. So according to this study, the FAAO study, Prospective Health Assessment of Cataract Patients' Ocular Surface, not sure if you've seen this.
This is Trattler's study.
I believe so. Yeah. Nearly 80% of patients coming in for cataract surgery have signs of at least stage 2 dry eye or worse. Stage 2 dry eye, that's a bad one. That's something that is impacting their life.
Yeah.
It's impacting their vision. And, a lot of these patients are not having that dry eye diagnosis even before that study.
And I would say that's right. In my practice, I'd say that 80% of these patients, absolutely, if not more. I mean, I feel like I diagnose everybody with dry eye preoperatively. A lot of them are asymptomatic, but if they have fluctuating vision, and they have any type of staining whatsoever, or redness, even some conjunctival staining, no corneal staining, I'm just diagnosing it because like we said, it's important to do that on the front end.
And again, if you tell them before that surgery's done, it's a them problem and we're going to help them fix it.
Yeah.
But if you wait and now you got the dry eye after cataract surgery, it's an us deal and it takes a lot of hand holding. So next slide. I'm going to leave this one to you.
Yeah, we've had some false starts. As I mentioned, when I came here, there's a lot of things that we weren't doing in this practice. And we were well known and we're doing a tremendous volume of surgery, but there was a lot that I had learned in my training and going to meetings and doing all the stuff that one does that I said, gosh, I'd like to add this and add that. I thought that if I could just bring some point of care testing and, add some services, some cash-based services through microblood exfoliation and some thermopulsation, that this thing would just take off. The challenge is that it's really hard for you to change the behavior of other doctors in your practice. And that's one thing that I want to harp on, for those folks watching this. You have to have a true practice champion because think about for a moment how difficult it is to change your own behavior, right? And then think about trying to change someone else's. It's very, very hard to do. So having to go speak to docs that have been, practicing for 30 and 40 years and, to explain to them about dry eye and these things that we can do now, to them, it's just kind of that old dry eye thing. And then they didn't really love the idea of treating it. But there's really been sort of, an evolution and really revolution in this space, particularly with younger doctors who are coming on board now that we have new, better diagnostics. We have better therapeutics. We have different and better pharmacologics, and everything's kind of come full circle. So, my stance on this is that, you have to have a fully functioning, high-end dry eye center if you're going to be doing a lot of cataract and refractive surgery. But more importantly, you have to have a practice champion, someone who believes in it, eats, sleeps, and breathes dry eye disease, who can really guide you and guide this process and take care of those difficult patients on the front end and back end. And so luckily, Josh has been wonderful in that role in our practice.
And one nice thing too is when you have a dedicated dry eye guy or a dry eye gal, for those really tough cases, you can send them to me rather than spending all that time in the room. Okay, we've tried this, we've tried this, we tried this. Being able to say, you know what, I'm going to send you to Dr. Davidson. He lives, eats, breathes dry eyes. He's our dry eye specialist at our dry eye center.
Yeah.
That takes a load off. And you know what? That also automatically gives the patient some comfort, saying, you know what? This is such a common thing. They've got a guy or gal that specializes in this. I'm going to go see that person.
Yeah.
And so oftentimes I will see a patient that one of our other docs has been seeing for 5 years, just not happy. But now we have this dry eye center. They come in bright-eyed and bushy-tailed, and they're excited. Okay, what can we do? What do you have? And you're already half winning the battle. And with all this advanced diagnostics that we have, I'm able to run these numbers through to them. I believe strongly that tier lab and MMP9 testing are pretty much standard of care in dry eye, in my opinion. And when I'm able to tell them their numbers and tell them they've got some, positive inflammatory markers, and I can show them on the keratograph, hey, this is what your eyes look like. Your tear breakup time is awful. You're automatically halfway there because you're showing the patient, hey, I understand what this problem is. This is why you're uncomfortable. And this is our game plan to get you there.
It's important that you remember it's not what you tell patients, it's what they remember.
Yes.
Okay. So one thing I love about sending patients to Josh preoperatively is it's very similar to when I send them to the retina doctor for a little mild ERM or something like that. Let's say it's a 20/40 cataract and they got a mild ERM. I know that the retina specialist isn't going to do a membrane peel on them, and they're certainly not going to stop them from doing cataract surgery if there's a significant cataract. But I send that patient anyway because in their mind, it cements that they have something else wrong with them that has nothing to do with the cataract. So because they remember going to sit in that other waiting room with that other doctor. So similarly, this can be a situation where if you send that patient to the optometrist that's taking care of the dry eye, I love doing that because they won't forget that. All that testing and stuff, they're going to remember going through that, and they'll remember that they have this other problem. So this is all leading towards the happy postoperative patient, right? So all this is sort of critical.
Yep.
So, again, why it worked this time has to do with finding the practice champion. I think that not everybody is going to necessarily have the skill and expertise and perhaps motivation that Josh will have, but I can guarantee you that if you spend time, if you're on this webinar, if you're already learning from this symposia, you're already ahead of the curve. You're way ahead of where you need to be. So you can kind of learn from this and sort of reach out to your different colleagues and try to understand how you could become a practice champion. One of the reasons why I think it worked is because, Dr. Davidson didn't really ask for the whole world up front. He didn't come in on day one and say, I want this toy, that toy, that toy. That's going to cost you $470,000.
I was a little greedy.
Over time, he has acquired toys that are very expensive. But he's done so always in a type of way that seems business minded, where he set a pro forma where we can't lose, and it makes perfect sense that we can see that service line. So I think that, that's my opinion on why this worked, is we had not only a practice champion, but someone who is able to guide us on how we can spend capital to acquire different diagnostics therapeutics that would ultimately grow our business.
Now, he's being humble because when I came in, I did want everything. I said, okay, we need this, we need that, we need this. And I'll never forget, what you said. And you said something very similar to what happened when you joined the practice. We looked and saw what you didn't have and what this practice didn't have. And that's what I noticed. I said, okay, we don't have this. We don't have this. We don't have this. And we need all this. And really, to start a dry eye clinic, you really need two things. Well, three. You need a little bit of dye. So fluorescein, lissamine, choose your poison. You need your finger to check those glands, and you need a slit lamp. That's really all you need. And then just patience, to talk to the patients themselves. And yeah, as we slowly grew, we got more and more things. And they've been really great with me because I would come to them and say, listen, we need an IPL. IPL is just the way to go. Oh, that's a big capital expense. Do you think that there's a demand for this? And they made me do a lot of research and really say, okay, is this really going to work? Do we really have the patient basis for this? And I mean, the Williamson team, the Williamson family are brilliant businessmen. And that's why they made me work and really see, hey, is this something that would actually be beneficial for this practice? When I came in, I wanted 3 different products. And you said, yeah, that's nice to have, but is it going to make financial business sense to do so?
Yeah. Is it a tool or is it a toy?
Exactly. And when I actually looked at all those 3 things, I never once went back to them and said, I really need it. Because none of those things, we really need it, in my opinion. And that was really a big, important moment in my evolution to create this clinic. You don't need all the whiz-bang gadgets. You need care for your patients. You need to be able to spend time with them. And you need to really understand the dry eye disease process. And then as that clinic grows, that's when you can get some of this stuff. So, one of the best purchases we made, I don't know if they're sponsoring or not, but the Oculus Keratograph 5M. That's been incredible. You'll send me a patient. I'll run the keratograph, print them off a crystal tier report. It's got our logo right on the top. And the patient says, wow, okay, this is everything I've got. This is what I've got to do. It's totally customized for them with their treatment instructions. There have been patients that have come in that have actually left me a negative review on our,
Calibrator.
Calibrator. I got a negative calibrator score one time. Never forget it. An older lady, in her 80s, and she had dry eyes. She saw us at one of our other clinics, not at the Dry Eye Center. And she gave me a 3 out of 10. I said, what in the world? I thought we did great. Her dry eyes are fixed. Everything's great. So I called her and said, hey, Miss Smith, said, I noticed you gave me a really bad, a bad review. And I just want to make sure that, whatever happened, I understand and that I can fix it because we want to make sure you're happy. Her only complaint was she didn't get a printout like her friends did. She came here because of that printout and the great experience the friend had to get her dry eyes fixed. We fixed her dry eyes, but she didn't get a printout. So little things like that little subtle marketing helps dramatically. So again, when I came in and really pitched the idea of the Dry Eye Center, it was really well received by Dr. Charles Williamson, by Dr. Blake, and the rest of the partners, and our CEO, Chuck. It was really, really well received. But, you made me do my work. Said, okay, how would you do it? What are you going to, how are you going to build this thing? And just by happenstance, we also got into this office, which is on the campus of the Baton Rouge General, which is a beautiful, large hospital complex. And just having this brand new clinic, that has really allowed us some organic growth too, because we're on a hospital complex. Hospitals are dry. Nurses are stressed. They're working long hours. They're not eating healthy. They're not drinking enough water. Huge dry eye clientele right here. And a lot of them are moms. So it's been great. So next slide.
And I'll tell you, it was important that we have our space here, sort of the Dry Eye Center in this type of space, because if we could turn the camera around, we'd show you, but basically we try to make it look like a hotel lobby. It doesn't feel like a random doctor's office here. And a lot of that is part of the flow for the typical dry eye patient who's a cash paying patient.
Yep.
That's why our refractive center here is also here as well. So tell us more about sort of the structure and flow.
Great. So that's a really good kind of big overview of this clinic. It's high end. It's beautiful. You walk up here, nice comfortable seats, big beautiful TVs that are showing our our wonderful successes with premium IOLs, refractive surgeries, dry eyes, a lot of the interviews we've done. So it's set up to kind of give that patient automatically that aura that, hey, these people probably know what they're doing, and kind of relax you. Because for a lot of these patients, they've been seen by 4 or 5, sometimes 6 eye doctors, and who have never been able to get to the bottom of their dry eye issue. So they're already frustrated. They're already coming in skeptical. They walk up, they see that big, beautiful Williamson Eye sign, the big, the wonderful staff that we have at the front desk with their caring smiles. It automatically screams legitimacy. So just the atmosphere is wonderful. When you walk back and the patient is taken back, we've got all these nice colored lights. It almost looks like a spaceship, but it screams high tech. So that's the first thing they did when they designed this clinic, was really give off that aura that, hey, we've been around a long time. We know what we're doing. We're going to fix you up. The big thing that I also mentioned earlier was, what is the bare minimum that you need for a dry eye practice? You mentioned the practice champion, which absolutely, you need that. You need someone that loves this stuff, because these patients, they're pretty challenging. They really can be challenging. We all have those patients that we automatically think of that they are just, they're buggers. And I would bet most of you, that patient is a dry eye patient. So again, the bare minimum, practice champion, you really want the stains. You really want to know that eyelid anatomy, that ocular surface anatomy. And again, what we started with was pretty basic, but it has ramped up very, very quickly. Really what we learned and what we needed to learn quickly was, it's not about what you have at the dry eye center. It's about kind of what you know, and just getting to the underlying, etiology of that disease process. That was the big thing that really, it took me a while to learn, and I needed to learn a little more quickly than I did. And they did a wonderful job of kind of breaking that down. And again, I mentioned this earlier, and one of the things that I think that if you're listening to this webinar, you're obviously interested in learning about how to grow your dry eye practice, or maybe even start your own. But financially, dry eyes, in my opinion, are the future of all of eye care. I really do think so. And the reason why is, again, people are getting it more and more. And as reimbursements for cataract surgery go down, premium IOLs are great for sure. But, that's a subset of the population. You do that procedure once, and they should be done. Yeah. Dry eyes are a chronic, progressive disease state. These are patients you're seeing all the time. And if you're going to do a cash paying procedure like IPL, they typically need maintenance. And again, you're seeing the typical dry eye patient of your female, not always, but typically your female who's a mom, 40s through 60s, sometimes older, who have got a lot of friends. They like talking. And if they've got a great experience, if you wow mom, everyone's going to know. Facebook's going to know. Their friends at church are going to know. Their husband is going to be coming in here for an exam real quick. And I wish there was a way for us to measure the downstream economic benefits of this. I'm sure someone on this call has got some great data analytics. But for example, I cannot tell you how many times I have seen a 65-year-old female, dry eye. She's been seen by 4 to 5 different eye doctors. She'll come into the dry eye center, get her all treated up. And I say, you really do need cataract surgery. Even though we've cleaned your vision up, your ocular surface up, you're still not seeing great. I would send them over to you, has a great outcome. And you know what? Husband's in my chair 2 weeks later. And oh, yeah, wife had cataract surgery, best thing since sliced bread. She's seen better than she could when she was a teenager. I need to do that too.
Yeah. So I think a big part of that is, it's a practice builder, just
Yes.
doing it. You're going to grow. You mentioned declining reimbursement for surgery, but I mean, gosh, contact lenses, 1-800 contacts, and
Yes.
Warby Parker and all that. I mean, gosh, if you're just making a living doing optical, that's not the future. So the future really is medical, and dry eye is a huge part of that.
Absolutely.
Next slide. So when I see a patient with dry eye, the first thing I do is make sure to put my hand on their knee or their shoulder, look them right in the eye and say, hey, you have a chronic progressive disease for which there's no cure called dry eye. But the good news is it's treatable, and there's all kinds of different things that we can do. And I'll just look at them depending on what their different point of care testing shows. So let's say that they have, high osmolarity, then typically we'll put them on some type of immunomodulation. Let's say that their MMP9 is high, then typically I'll do some steroid therapy as well. And then I just have them come back and see me in about a month. I'll retake the topography and tomography measurements, and I'll often compare, and it's crazy how many patients you can rule in or rule out to, let's say, a toric lens. Their Ks can change, and both the magnitude and the meridian of the cylinder can change dramatically. And I've presented on that multiple times. So that's kind of where I start. I also want to make sure that I'm looking at their lids. We know that MGD is the root cause of all this. And if I see someone who not only has some staining and has some high osmolarity readings, but also has some blepharitis and also has some meibomian gland disease, that's typically the patient that I'm sending to Dr. Davidson. If someone just comes in and they look okay, but their osmolarity is uneven or high, typically I can start them on something, see them back in a month, make sure that their refractive readings, both the biometry and the topography, are stable in terms of their Ks. And if they're cruising, we go ahead and do surgery. But really, it's those patients that have sort of the underlying MGD blepharitis as well. That is typically who I'll refer on to your way. And at that point, you kind of take it over.
Patient gets sent over to me, and there is no definitive treatment algorithm. I don't have this set protocol that I always follow every single patient. And I don't think that's actually possible because there's new stuff coming out every single month. You've got nasal sprays now, different types of steroids. You've got cyclosporin going generic. There's all sorts of different things happening in that dry eye space, as well as, of course, the lid issues too. There's all sorts of machines and gadgets and all that. But what I typically will do is, so if a patient gets sent from me, from you to me, or from one of the other providers, I will get them cleaned up. So if they've got their bleph, we're going to do a lot of Acusin. We might even do some lid wipes, but we're going to hit them with some spray, whether that's Avenova, Acusin. I'm a huge believer in reducing that inflammation. So I will almost always throw that patient on a steroid for a couple weeks. Get all that taken care of. Also a big fan of warm compresses. Let's get that oil flowing. Let's see exactly what that tear film looks like with the heat, with the Acusin and the steroid. And I'll bring them back in a couple weeks. And usually at that point, for the vast majority of our patients, they're actually good enough to send back to the surgeon, because everything's all cleaned up. They've got it in their mind that, hey, I do have dry eyes. I've got this chronic disease that does cause fluctuation in vision. For those patients that are getting sent from area providers, I know those are the ones that are going to be a little tougher. So our regional and local optometrists, those are the ones that have probably tried the steroids before. They've tried all sorts of different things. So that's kind of a case-by-case basis. We've got an IPL here that is really going to be a godsend for a lot of those patients with the telangiectasia, the eyelids, a lot of those patients that are just on all the drops, all the ointments, all the creams. But for the most part, what I do follow is that Deuce 2 and a little bit of the Cedars algorithm. The Deuce 2 is is such a strong algorithm. And we've been getting a lot into scleral lenses, not for these scleral or these surgery patients, but we've really been getting a lot more into that. So what I'll typically do is follow that DEWS 2 protocol, and I kind of go from there. Also, one of the really interesting aspects is when a patient comes to us, kind of an organic patient. So let's say I treated this woman, 65-year-old woman, dry eyes, treated her up. Then you did wonderful cataract surgery. She's happy as a clam. Everything is great. But now her husband comes in. Husband always has blepharitis, always. And so, that's one that I will not send over to you until I find that those lids are darn near perfect and that their surface is flawless, because I don't want to waste your time. I don't want you to look at them and say, oh, they're not quite ready. Do this, see you back in 2 weeks.
Yeah. Or, worse yet, what if I was really busy and I missed it? What if I'm just slamming through a 50 or 60 patient day and I don't take the time to stain the cornea, right? That happens at times. I'm not perfect. And so, everyone gets busy and sometimes you miss things. So, if you're working with a surgeon that perhaps you don't think is going to take the time to look for that stuff, well, you better treat it, yourself.
Exactly.
And get them teed up.
Yeah, and teeing up is a great term for that, because when I feel strongly that when I send a patient over to you for a cataract evaluation, their lids, their ocular surface better be flawless. And a lot of times, to be honest, what I do is if they've just got trace bleph and you've got some capped glands and all that, I will do that kind of the BlephX or the Bruder mask. I will do the Acuison twice a day. And then I'll hit them with a steroid or something like Toberdex ST. I'll hit them with all that and not see them back for a follow-up. Just send them your way, because I know that is going to be good enough. And that is going to be really, really good by the time they get to you. And they'll be ready for all their testing and all their readings. So case by case, there is no set treatment algorithm for it. When you do a lot of this, you kind of get a feeling of who's going to respond well and who's not going to respond well.
Yeah. Next slide.
Next slide. So the future of dry eye, this is where things get really, really interesting. It's growing, and I feel strongly that this needs to be a huge aspect of Williamson going forward. And I'm very ecstatic that our management and the providers do seem to kind of go along with that. Dry eyes are one of those very interesting disease states where it's cash pay for a lot of this. And so cash is king. You're fixing patients and they're paying cash for it. We're avoiding a lot of the insurances for these procedures. And again, as we talked about, as the reimbursement rates for a lot of these medical procedures go down, cataract surgeries going down, all that, having this whole avenue stream or revenue stream is going to be huge for large clinics and small clinics alike. So my biggest recommendation is, if you have a surgery center, you really need to look at really appreciating dry eye for not only the fact that it can help your surgical outcomes, it can help your patients dramatically, but it can really help the bottom line.
Yeah. Yeah. And, I would say, to add to that, certainly the business of dry eye is huge. And it's sort of like the refractive space in ophthalmology, the dry eye space is in optometry. I feel like that's sort of 1 foot in the cash pay game, 1 foot in the insurance game. But even more than that, the future of it for me is, having an entire generation of docs that are coming out now that embrace this for once. And embrace that, that patient who has seen multiple doctors that no one really took seriously or, cared to kind of go through the different algorithms and offer all the best diagnostics and therapeutics. There's a lot of patients out there that need our service. And I think it's important that everyone that's watching this really embrace that role, because if you do, I think you can really transform someone's life. For the first time ever, these patients have someone that actually care about the dry eye, right? And the great part about it is you don't have a whole lot of skin in the game in terms of you didn't cause their dry eye. It's not like something that you did wrong. And so you're kind of not looking forward to seeing this patient. They have a chronic disease that you're just helping them. So God forbid you do something and it fails. Well, guess what? It's dry eye. It's kind of like glaucoma. A lot of patients say, gosh, I did the MIG surgery, or I did the SLT. My pressure's still going up. What's going on? I said, you have glaucoma, right? So dry eye is kind of like that too. There's not a lot of high stakes in it. So therefore, because there's really no risk to you, it's all reward. And I don't mean financially. I just mean sort of in how you feel about yourself going through your practice and all the different lines that you can touch from this. So I love sort of what you've done here, and I'm really excited about seeing the future and how this goes forward.
And something to keep in mind: if you don't embrace dry eye treatment, someone else will. You've got huge numbers of new optometry graduates coming out, and they are more well-trained than I ever was. And I've just been out for 9 years, and, exponentially better than those that were out 20, 30 years as far as training goes. They are going to see these patients. You might as well team up with them. And that's the big thing. If you don't want to treat dry eye, someone else will, and they're going to grow their clinic quite a bit.
Yeah, I agree.
Yeah. So yeah, this has been great. Thank you for taking time out of your busy schedule. He's really active now on TikTok. I don't know if any of you all know that, but what is it? Williamson LASIK?
I don't even know what it is. We have multiple different social accounts and people are logged in,
Yeah.
but we were doing a TikTok dance, practicing.
What were you doing?
The Celine Dion challenge.
Yeah.
Google that. Look for that. It's coming out within the next day or two. But thank you guys for spending time with us.
Absolutely. Thank you so much.
Wow, Blake, Josh, that was a fantastic session to end our first evening of Eyes on Dry Eye 2022. I've got Josh Davidson here with us live. I've got a couple takeaways maybe that you can comment on. The things that I was writing down looking at that session. To really be successful in the dry eye space, you need to have a practice champion. And in your practice, that's obviously you, Josh. And then the second thing was, if you really want to have a fully functional premium refractive cataract practice, you have to have a fully functional dry eye center. Would you agree, Josh?
I really would agree with that last statement. Patients are coming in, and especially if they're getting these premium IOLs, they're paying a pretty penny for they're paying a pretty penny for really the best of the best. And if you've got a disturbed ocular surface, then you're actually going to be stopping a lot of that light from focusing correctly. So you really want to take all the extra stuff and all the factors that could cause a decrease in vision out. Dr. Blake mentioned that, if there's even a minor ERM, he's going to send that patient out. And that also might disqualify him from the premium IOL. But I think at this point in clinical practice, we've got the tools to actually treat a large majority of this dry eye and give those premium IOL patients the best possible outcomes. And there's a difference. There is a difference that we find between those patients that maybe get premium surgery elsewhere and those patients that get premium surgery from us that actually visit our dry eye center.
Yeah, you're really turning a non-candidate into a great candidate. It takes a little bit of time and education up front. Occasionally in my practice, there's patients that we just can't get turned around, and we say, boy, we'd love to be able to use this implant, but your ocular surface just is not compatible with that. But we will give it a good try for a few months to make sure that we can turn that patient around. And a lot of patients do really well. They just need a tune-up before surgery.
Something else too to add to that, when we've got all this data, and for those patients that we just can't turn around, like you mentioned, we're actually able to tell them, hey, we do have all this great technology. Some of your friends, have this great lens, but here's why we're choosing to not do it to you. And they appreciate that. They understand that, hey, that technology's out there. I do have this chronic progressive disease process that's actually so bad it limits me from, doing that surgery, that premium IOL.
Yeah, I think people want that honest conversation. If they're non-candidate for whatever reason, is tell them why, so that they're not disappointed in maybe what their friend or relative had at some point earlier.
Exactly.
We have a question from Shannon. She is wondering, what products do you recommend to really clean up the eyelids, and why do you prefer those products?
Well, if you're going to really clean up those eyelids, obviously you want to clean them up with a BlephX or some other tool there to actually exfoliate those eyelids. So that's going to be the best, obviously. But honestly, just some plain old, I'll do a lot of OcuSoft lid wipes. I'll do a lot of Acuisin, Avenova, and then of course Doxy and all that good stuff. But I'm a big believer in hypochlorous spray. And you pick your poison. I feel they're all really good, but I'll have a patient do that 2 to 4 times a day, depending on the severity, for at least 2 weeks. And then of course a lid scrub as well. But yeah, there's nothing quite like BlephX.
So BlephX, hypochlorous spray, and then some sort of mechanical lid wipe along with that. So with that in particular, and you had mentioned this in the chat, you're using Dry Eye Rescue, and I use that as well. And they're in an exhibit hall. I mean, they've got a really cool booth because they've got a whole bunch of product lines within that booth. So check that out. But I know you're a big fan of everything that they offer. How does that help you get patients the products that you recommend without you having to carry a million different things in your practice?
Great question. So, really, I came in and you kind of got the breakdown there. I came in, bright-eyed, bushy-tailed. I wanted everything, and I wanted to carry every product out there. But every time you carry a product, that involves stocking, that involves ordering. It's very challenging, and so I actually was able to find Dry Eye Rescue just organically. And what's great for them is I've got this nice little sheet. It's a tear off. I've got all these different products. We don't carry iSeals 4.0. I don't carry High-Low Night. There's all sorts of great products for Generized. And so what that allows me to do is I just rip off this paper, write down their diagnosis, circle the products that I want, and hand it to them. And I know the patient can get those products. And what's also really, really nice is we get a little cut from it. We're not going to retire on that, but it's nice that we get a little bit of something. And it also shows us that, hey, the patients are getting their products. So it's worked out really, really well for us. And it was really nice for our management because, again, they didn't want any more work for our opticians or our front desk staff.
No, I think a lot of great things there. Be able to leverage that to get patients appropriate products and really have the outcomes that you can get them. Question here about, you talked about the relationship that you and Blake have, and he's sending you patients across the hall that are in for cataract refractive consult. They need a tune-up. You're seeing a patient that has maybe dry eye and cataract, and you get them taken care of and then send them to Blake. But what's been your strategy in Baton Rouge to be able to get external referrals into your dry eye center?
Great question. Really where we've got a lot of our external referrals are actually corporate ODs. They want to treat dry eyes. They want to learn about dry eyes, but a lot of them unfortunately just can't with the high volume. And so just went over to those folks, just said, hey, this is what we've got. This is what we do. Come on over, check out the practice, see what you think. And, kind of did a little Q&A with them, showed them everything, keep them up to date with all the technology. We get a lot of our external referrals from corporate ODs. And those folks are great. I adore all of them. As far as a lot of the private practice ODs, we do get a few private practice ODs sending us their dry eye stuff, but a lot of dry eye, it can be managed by most people. If you have an interest in it, you can do it. Most of the private ODs around here are great at managing dry eyes, so they keep them in house, and that's totally fine. A lot of our MDs, our retina folks, will send over to us as well. So it basically just putting your face out there and letting them know that we support them, and that anytime they have any issues, here's my cell phone number. We're going to send them a really good report. What I've found is that a lot of young ODs that are working corporate, if you send them reports for pretty much every patient, they love it because they're learning, they're keeping their skills up to date. They're like, okay, well, Dr. Davidson shows this. Why didn't he choose this? Oh, that's interesting. And we'll call and we'll talk about it. So that's been a huge, huge growth aspect for us is the corporate ODs.
As we wrap up the session, how to implement a dry eye disease protocol in a surgical practice, what are your final takeaways for our attendees at Eyes on Dry Eye?
I got two really big takeaways. The first is that if you, whether you're an OD that's sending to a surgical practice, an OD or MD at a surgical practice, if you don't tell the patient that they've got dry eye before they have the surgery, whether it's cataract or refractive, then it's your problem. If you tell them beforehand, then it's a them problem that you can help them fix and actually alleviate. So that's a big thing. If there's dry eyes there, tell the patient, okay? Even if it's a mild dry, tell them. And the other thing too, and we brought this up twice during the presentation, is one of the beautiful things about growing a dry eye practice for anyone, any practice modality, whatever it may be, is again, your typical dry eye patient is your female in the 40s through 60s, 70s, but kind of that middle-aged female. And those are the medical decision makers in the house. They are the ones that are actually deciding, hey, you're going to this doctor at this time for this thing. Oh, that's bothering you? Here, I made you an appointment. It's next Thursday at 4, whatever it may be. So you're grabbing those patients that will then have a huge economic basically downwind. They'll really grow your clinic in a lot of different ways outside of dry eye.
Josh, I got to jump over to the exhibit hall. So we're going to wrap this up. How can people get a hold of you if they want to connect a little bit further? What's the best way to do that?
Best way is email. It's J Davidson, DAVIDSON at WECEYE.com, WECI.com. Again, J Davidson at WECI.com. If you've got questions for me or Dr. Blake, he wasn't able to get on. He's somewhere traveling, lecturing about cataract and refractive surgery. I think he was in Aspen a couple days ago, but I can get a hold of him and find that answer out for you and get back to you.
Thanks, Josh. Great session. I'll see you around this weekend. I'm going to get back to the exhibit hall. Thanks again for joining us on the
Thanks, Damon.
implementation track at Eyes on Dry Eye.